My name is Dr. Richard Sheldon. I'm a pulmonary and critical care physician. Thank you for allowing me the opportunity to take this time to discuss with you an important aspect of critical care medicine, non-invasive positive pressure ventilation. Non-invasive positive pressure ventilation has become important in the management of respiratory insufficiency and respiratory failure, as techniques for improving the patient's dyspnea by this method has advanced. One of the major tools used in non-invasive positive pressure ventilation is the ventilatory mode known as continuous positive pressure, known as CPAP. CPAP is known to lessen dyspnea by improving pathophysiology in two general areas, pulmonary mechanics and hemodynamics. CPAP improves pulmonary mechanics by recruiting microatelectatic alveoli and improving diffusion capacity. Hemodynamics is improved by reducing preload and afterload, plus reducing left ventricular transmural pressures. Studies have shown that CPAP is therapeutic when applied to patients in both lung and heart failure. The end result is that CPAP has been shown to reduce the need for these patients to be intubated and placed on mechanical artificial ventilators. One area for the need for non-invasive ventilation is growing, and this is the area in the care of patients with heart failure. Heart failure is considered to be a near epidemic status in the United States. Patients with heart failure account for 12 to 15 million doctor office visits each year. 300,000 patients die each year of heart failure. There are many predisposing factors to heart failure, several of which are on the increase, such as diabetes. The diagnosis of congestive heart failure is made by history and physical examination. A sensitive new marker for congestive heart failure, brain natriuretic peptide, has become available to help in the diagnosis of heart failure. Not only is the death toll from heart failure appalling, but also the economic costs which strains our healthcare delivery systems. Approximately 5% of the total United States healthcare budget is spent on heart failure alone. 25% of all hospital admissions are for heart failure. The average cost for each patient is approximately $10,000 to $12,000 for an average length of stay of 6.7 days, while the reimbursement rate is approximately $4,500, thus making heart failure patients a major economic burden to hospitals. If a patient in heart failure avoids intubation and thus an intensive care unit stay on a ventilator, their length of stay is greatly reduced. The reduced length of stay transforms into less of a loss of revenue to already cash-poor hospitals. Frequently, the first responders to a patient in heart failure are the EMTs, who arrive at the patient's home in response to a 911 call. The ambulance crews need a simple and sturdy non-invasive CPAP unit that can be taken into the home and attached to the patient while the crew is assessing the patient prior to the ride back to the hospital's emergency department. Time is of the essence in these instances. Starting CPAP therapy early during this period of time makes the difference between whether or not the patient requires intubation when they arrive at the hospital. Currently, there is only one CPAP unit on the market, which is portable enough to be used in ambulances and can be taken into the patient's residence. This unit does not consume so much oxygen during the transport of the patient that the ambulance runs out of oxygen before completing its life-saving run back to the hospital. This unit is the Portovent developed by Emergent.